I am Dr. Ruth Michaelis, and I'm a family physician at Health Point Community Health Center in Washington State. I am also faculty at the A.T. Still University School of Osteopathic Medicine in Arizona, which embeds students in community health centers for their last 3 years of medical school. The patient experience has eclipsed many other measures in our quest for healthcare quality improvement, as it is linked to both healthcare outcomes and patient satisfaction. Healthcare leaders are prioritizing the patient experience through laws like the Affordable Care Act to change the direction of reimbursement from quantity to quality. Patients have long filled out patient satisfaction surveys, which actually do correspond to places that provide better quality of care, not just to patients recommending their doctor to family and friends. But patient surveys often just allow us to compare services against our goals and don't always provide direction on how to improve. In order to improve the patient experience, we have to continuously identify and subsequently resolve issues by addressing fundamental processes within the organization. One of the tools with which to address these processes is through lean methodology. In this set of projects, some scholars focused on identifying patient experience issues by measurement surveys of overall patient satisfaction, in-house pharmacy satisfaction, accessibility and usability of mobile technology, chronic disease visit intervals, and hypertensive patient needs. The other scholars focused on changing clinic processes, resulting in decreased wait times prior to appointments and decreased time providers left exam rooms during appointments. Here are the scholars' projects focusing on improving patient experiences.
Hello, my name is Delphine Kohler, and I am a medical student at Marian University College of Osteopathic Medicine. I was assigned to Adelante Healthcare in Phoenix, Arizona, where my project was to research standing orders for use in the patient-centered medical home model. Standing orders are best practice guidelines that are established by physicians but can be implemented by support staff such as nurses or medical assistants, with the understanding that these orders have been pre-approved by physicians at the executive level. In this case, the standing orders that I submitted are to be approved by the Director of Clinical Programs and the Chief Medical Officer at Adelante Healthcare. The standing orders I helped to develop were for hypertension and preventative health for both adults and children. They are to be incorporated into the Adelante healthcare system with the opening of their new site in Peoria, Arizona, which is designed to implement the patient-centered medical home model for all patients. In addition to this project, I surveyed healthcare providers at Adelante Healthcare to gauge their perspective on the use of standing orders in the primary healthcare setting. I understood the majority of physicians or healthcare providers to be in favor of standing orders, where most of them view standing orders as a means of increasing patient compliance, improving the overall quality of healthcare and provider productivity, while also decreasing workload. As a result of my project, I firmly believe that the standing orders in the patient-centered medical home model should be beneficial to both patient and provider, and that Adelante Healthcare should proceed as planned with implementing the use of standing orders in their new PCMH site. Thank you.
My name is Evelyn Escobedo. The title of my research is Physician Empanelment and Patient Revisit Intervals in the Era of Healthcare Reform. It is an analysis of appropriate follow-up intervals for patients with chronic conditions in a federally qualified health center. The objectives to my research were to conduct an analysis to deliver providers with appropriate follow-up time intervals for patients with stable, uncomplicated chronic conditions. The ones I focused on in this study are hypertension, diabetes, and hyperlipidemia. Additionally, I wanted to survey providers on their thoughts on appropriate revisit intervals. For my methods, I conducted a PubMed search for literature guidelines of revisit intervals for patients with stable, uncomplicated conditions of hypertension, diabetes, or hyperlipidemia. I also collected data on Ultimed's current utilization rates for patients diagnosed with these conditions. Ultimed is a federally qualified health center in the greater Los Angeles area. Additionally, providers were given a survey about their thoughts on appropriate revisit intervals for their patients. The key findings in my research were the following. The guideline for the revisit interval for patients with uncomplicated stable hypertension in the literature is that it should be greater than 6 months to less than 1 year. There is no literature to support guidelines for appropriate follow-up intervals for patients with chronic, stable, uncomplicated diabetes or hyperlipidemia. Ultimate's current average annual utilization for patients with hypertension is 5 visits per year. Providers feel differently about the appropriate follow-up time interval for patients with the condition studied. However, there is most agreement that for hypertension and diabetes, 6 months is an appropriate follow-up interval, and for hyperlipidemia, 1 year is an appropriate follow-up interval. Providers do feel comfortable extending their follow-up time by 1 month. And my recommendations to the organization were to identify providers of highest utilizing patients with uncomplicated hypertension and identify what are the variables amongst these providers to best support them. Additionally, to provide ongoing yearly provider guidelines or education seminars to maintain organization-wide baseline on follow-up intervals. And my final recommendation is that it would be beneficial for the organization to supply their providers with appropriate guidelines for diabetes and hyperlipidemia.
Hi, my name is Fatima Fahimezin. I'm a medical student at Howard University College of Medicine in Washington, D.C., and I did my project at Health Point in Seattle, Washington on minimizing wait times through integrating behavioral health during well-child checks. Health Point is a unique community health clinic in that they do have a behavioral health consultant at almost every site within Seattle, and that allows patients to have a specialist to speak to about behavioral health care. So that can be anything from smoking cessation to parents struggling to find ways to take care of their kids with like picky eaters and things like that. And so what I wanted to specifically do was integrate behavioral health with pediatric visits to see if we could decrease the time a patient has to wait in the exam room for their physician to come in and conduct a physical exam. So for 2 weeks, I went ahead and recorded what is currently being done at the site. So a patient gets called in by the medical assistant, they get their vitals taken, they're asked a couple of questions about why they're coming in today, and then they're left alone for maybe 15 or so minutes until the physician comes in to do their physical exam and just go over basic patient education related to that child's age. So for example, a 4-year-old might have a discussion about stranger danger, whereas a 15-year-old may have a discussion with the physician about safe sex. So for 2 weeks I recorded that, and then for 2 weeks I conducted the intervention phase where instead of the patient waiting in between the medical assistant and the physician visit, behavioral health would come in and talk to that patient about their patient education segment of the visit to allow the patient to have a lower wait time and for the physician to have more time dedicated to the physical exam rather than both the physical exam and patient education. What I found was that involving behavioral health does decrease the wait time. However, it increases the overall visit time for the patient. And so what I recommend for the site due to the few weeks that we had to conduct this project is to continue to collect observations to see in the long run how this affects the clinic as a whole as well as the provider schedule if the visit time does increase, and just to collect more data so we can evaluate the differences in cycles or the different processes that each physician has to complete during a pediatric visit. I also recommend assessing the patient and parent satisfaction of involving behavioral health to see if they do prefer having a consultant come in and explain those things rather than just seeing their physician as the only person. Finally, you could do a longitudinal study to see if children who are involved with behavioral health during their well-child checks have a smoother transition through adolescence, or if they contact behavioral health more often than those children who do not get the intervention. So that was my project. Thank you.
Hi, my name is Christina Nguyen, and I'm currently a GE NMF PCLP Summer 2014 Scholar. I'm from the Chicago Medical School at Rosalind Franklin University of Medicine and Science. This summer, I was placed at Adelante Healthcare in Phoenix, Arizona. Today, I'll be discussing my project, which is titled Measuring Patient Satisfaction and Experience at a Community Health Center. My interests include primary care, especially women's health, patient satisfaction, and I wanted to learn about how the patient's visits affects their overall patient-provider relationship. So my objective was to survey OBGYN patients to better understand how well the providers are delivering care and to assess the patient-provider relationship in order to improve patient outcomes. The methods included random OBGYN patients at 3 Adelante healthcare locations, Surprise, Mesa, and Avondale, who were given pre- and post-surveys to complete during and after their visits. There were a total of 97 surveys completed by female patients from the 3 locations. Based on these findings, patients were more engaged and involved in their clinical management because they remembered everything they wanted to ask after filling out the pre-visit survey. Based on the post-visit survey results, patients had greater satisfaction with their quality of care, with a rate of 96.9% increased patient satisfaction. Overall, the patients stated their providers addressed all of their questions and needs. My recommendations include to first create a standardized survey for each specialty for the patients to complete on the patient portal during their visit to each location. Secondly, the healthcare providers should also collaborate with the Director of Clinical Programs to create survey questions based on the providers' communication, safety, efficiency, and effectiveness in order to assess which providers need more training. Thirdly, each patient should be surveyed within each department in order for Adelante Healthcare to get a better understanding of which quality criteria need improvement. Thank you.
Hello, my name is Jordan Rivera, and my project is titled Mobile Phone and Internet Access Among Low-Income and Homeless Populations. And essentially, the objective of this project was to assess if information technologies such as mobile phones, internet, and computers were accessible to the target population at a local community clinic on Skid Row here in Los Angeles. And I also wanted to see if patients would be willing to use that information technology in managing their health care. So I went about this by developing a validated, bilingual 28-question questionnaire that essentially collected information on demographics, on housing, and technological accessibility, as well as the preferences that a patient has when they want to communicate with their medical provider. And there was a total of 100 participants. Some of the key findings that are relevant was that accessibility to information technology was actually higher than expected for this population. 82% of the patients that were interviewed had access to cell phones, and 61% could actually access internet from their cell phones. They knew how to do that. But some things that we found out were that primary language, so a language other than English, could pose as a barrier to using information technologies, as well as if they lacked computer or hands-on technological skills, for instance, due to age as well. So some of my recommendations for this community health center was to basically have a greater effort on the clinical staff to secure emails from patients that already have them, to collaborate with transitional shelters in order to sign patients up for using a portal system, and also offer short information technology lessons here at the clinic. Lastly, I would also recommend perhaps looking into mobile platforms or app interfaces to reach the majority of patients that utilize cell phones to access internet and email. Thank you.
Hello, my name is John Tu Solomon, and I'm a second-year medical student for Morehouse School of Medicine. My site placement was the Matthew Walker Comprehensive Health Center in Nashville, Tennessee. The title of my project was a needs assessment of hypertensive patients. The objective was to complete a thorough needs assessment of the patients with hypertension at the clinic. This was done by giving adult medicine patients surveys with questions on diet, exercise, medication, and lifestyle. Participants were also asked to give their suggestions on ways to help them manage their hypertension. Key findings were that patients understand what choices are healthy, but they're not making those choices. Also, patients didn't have a good understanding of what obesity actually is. Combating obesity will help those patients manage their health condition. Recommendations from this project include more clinic educators who could help engage the patients and promote healthy lifestyles, to cut back on costs. Graduate students or undergraduate students interested in medicine could serve as clinic educators and check in with the patients between visits, make schedules and do those sorts of things to keep close contact with those patients. Another good resource to recommend to patients is the 1 Million Hearts Initiative by the United States Department of Human and Health Services. The goal is to prevent 1,000 heart attacks and strokes by the year 2017. They have a website that has a lot of information that will be instrumental in helping these chronically ill patients prevent any other comorbidities. I would like to give a thank you to Dr. Michelle Williams, Dr. Dana Marshall, Dr. Oberholly, and Dr. Gaskins, who were my main points of reference for this project. I really enjoyed doing it. Thank you.
My name is Hunter Spencer. I was working at Health Point in Seattle, Washington. My objective with this project was to eliminate room exits using a lean approach. This came about because on the very first day of my clinical shadowing, I noticed a particular habit that was occurring a couple times throughout the day that was driving me a little bit nuts. My provider had to exit the room a few times to grab simple things that should have been there anyway. And as I was thinking about this a little bit more thoroughly, it became obvious that this was both a waste of time and motion. Wasted provider time as well as patient time. So I started to think of ways to make this better. What I came up with first was to do a little bit more digging, asking more of the 5 whys, and I investigated why exactly this was happening. To do that, I used a standardized rubric for grading 5S adherence and found that although each of the rooms were very neat and orderly and had been usable, no one had really been complaining about them, they were not lean. There's a difference between just being neat and actually being lean. So after that, I began to intervene by standardizing the rooms, creating a more simplified approach so that the MAs could instantly visually detect when something was running low or needed to be restocked. And then we used a Kanban card system to allow replenishment or restocking. The way that works, if you're unfamiliar, is a simple little card that has a picture of the item, the quantity that should be in the room, the quantity that is like your target threshold for when restocking needs to take place. And that system has been used a lot throughout lean culture and Toyota production systems. Very successful. We brought it into the clinic. Finally, I did a direct observation of room exits. I noticed that room exits did in fact decrease after this standardization. Furthermore, when I went back and looked at the room exits, in particular, it was the items that hadn't been included on the original standardization that were the ones that were still causing room exits. And also, when I reassessed the rooms using that 5S adherence rubric, it did in fact change and persist for at least 2 weeks. So my recommendations are to apply this 5S intervention to all the rooms at the clinic that I was working at, and then expand the standardization list so we don't have those persisting room exits. Finally, the one area of 5S that was not improved in my intervention was self-discipline, so I want to display and document 5S adherence to bolster that aspect.
My name is Danielle Thomas, and I attend the University of Miami Miller School of Medicine. This summer, I worked at Health Point in Seattle, Washington. I chose to do my research project on barriers to the in-house pharmacy at Health Point. When I began this summer, I was very impressed that of the 13 locations of Health Point, almost all of them had medicine dispensing capabilities. However, after working for a few days, we learned that there was a low utilization rate by the patients, and I wanted to investigate if there was a significant barrier to patients using the pharmacy. I selected 2 clinics to do research at: Kent and Federal Way in Washington State. I developed a 1-page questionnaire that had questions about their current pharmacy, how they feel about their interactions with the pharmacist, and just what they value most in a pharmacy. I was then translated to Spanish. I received about 70 responses, 50 from the clinic and about 20 from the Federal Way clinic. What I learned was that HealthPoint scored comparably to other pharmacies. It was accurate, it was fast, and patients actually felt very good about their interactions with the pharmacist. In the questions about what patients valued most, overwhelmingly, I learned that they really value the time that they spend with the pharmacist. They want to feel like the pharmacist cares for them, that they're looking out for drug interactions, and that they have a home. My recommendations from this survey is that HealthPoint should capitalize on that health home aspect of the community health center. It's where they go for their dental care, it's where they go for their medical care, and it can also be where they go for their medication needs. And if there is a problem, everyone is in the same building and there's the availability for collaboration. Also, in my observations, I learned that patients are given the opportunity to select another pharmacy, and it would perhaps be better if the opportunity to select another pharmacy was omitted and the HealthPoint in-house pharmacy offered instead.